Good morning, everyone. Thank you for joining us bright and early on this first day of the CCMC New World Symposium. It's great to see all of you here. I'm Renee Taylor, Medical Science Liaison for Dexcom, a manufacturer of continuous glucose monitoring devices and the sponsor of this continuing education program. It's my pleasure to introduce our speaker this morning. Dr. Nicholas Argento is a senior clinical endocrinologist at the Maryland Endocrine and Diabetes Center, where he serves as the Diabetes Technology Director and spends 90% of his time treating patients with diabetes. Dr. Argento also serves as a representative for the Endocrine Society. In this role, he has testified to the FDA as part of a successful effort to get certain CGM devices approved as a replacement to traditional fingerstick testing and to CMS, which contributed to the approval of Therapeutic CGM coverage for Medicare patients in early 2017. Without further ado, please welcome Dr. Argento.
Well, thank you. You have the mic on. Okay, good. Well, so when you see a good crowd in the morning, you know either the coffee is good or the food is good, or you're really interested. Maybe a combination. They're not mutually exclusive. So my name is Nicholas Argento. I'm a clinical endocrinologist. I also have type 1 diabetes, so I have a lot of personal and hands-on experience with what we're going to be talking about here. So our agenda today, our objectives, so what we want to do is look at how patients can use CGM data and clinicians to improve diabetes control, right? Diabetes out of control is a very expensive problem, and we want to get a handle on this. So review some of the clinical evidence that supports CGM as a standard of care that's accepted as, at least for certain patients, as a standard of care by ADA and Endocrine Society, Association for Clinical Endocrinology. Also update the information where the thought is that, well, try an insulin pump first, and if all else fails, then use continuous glucose monitoring or CGM. And we have data to say that that's really not the best way to approach it. Look at some of the things you can do with the data in terms of sharing and data analysis, and also look at cost savings, right? So ultimately, you'd like people to be able to use a device, but they have to be able to afford it. And of course, for people who are looking at fiduciary responsibility, you have to hopefully offset cost as well as increasing cost. So this is just to make a simple point, and if for people who are case managers, diabetes patients, if they're not doing well, can certainly need a lot of resources to deal with it. And so there's an estimate that 3 out of 4 patients aren't following their insulin instructions. Only about a third of patients who are on insulin actually have an A1C less than 7. 7 is the general goal. And actually in type 1, it's even worse. The type 1 diabetes exchange showed that only about 20% of patients, even in academic centers, have an A1C less than 7. Also, hypoglycemia is going to be a recurring theme here, and it's important to keep a focus on this because long-term, you're worried it's sort of like trying to prevent rust. It's a long-term process for high blood sugars. But for low blood sugars, that's like getting struck by lightning, right? That's a problem right this minute, and it has to be dealt with immediately. So people on insulin get hypoglycemia. It's almost inevitable. So something like 90% of patients with type 1 diabetes will have at least one hypoglycemic episode a month. So it's really part of the landscape for them. And we sometimes think, well, type 2 is an easier process. But we also are seeing more and more patients with type 2 diabetes that are also on insulin. All right, so there's all kinds of things we can do short of that. But ultimately, if you don't make much insulin, somebody with type 2 diabetes starts to look like a type 1 person with insulin resistance. That is, they need intensive insulin therapy, basal insulin, and pre-meal insulin. Hypoglycemia, severe hypoglycemia where somebody else had to intervene, is a very serious, expensive, frightening problem, and it accounts for 4 to 10% of deaths in type 1 diabetes. most frequently at night. And also it's associated with higher mortality for our type 2 patients. So if somebody had one severe event, the likelihood that they're going to have a cardiovascular event or die within the next 3 to 5 years is actually markedly higher compared to other patients. So fingerstick monitoring was a revolution when it first started and to be widely available. So I personally have type 1 diabetes. I was diagnosed in 1968. No finger sticks at that point, so it was impossible to regulate blood glucose. So in about 1980, finger sticks became widely available. So this was a second revolution, but it's got limitations, right? So some of those things is it only tells you what your blood sugar is right now and not where it's going, and therefore, I'll show you an example of this. You only have part of the story. It then therefore can't predict when somebody's going to be hypoglycemic imminently, which is a limitation. And also, I haven't figured out how to get people to check their blood glucose at night when they're sleeping, right? If you can figure that one out, you're probably doing pretty well right here as well. But so that's a major thing. And for children, that might be the parents getting up every day at 2 a.m. to check Johnny's blood glucose. Also for patients, this is a thing, there's a stigma, it's blood, with all the concerns about biohazard in the workplace. I mean, imagine right now if you had to do a finger stick, you could probably do it discreetly, but if you're at Starbucks, that's not so, right? So chances are you're not going to do the finger stick. So there's a lot of limitations of finger sticks. So the way to think of CGM, or continuous glucose monitoring, this is a behavior modification device. It's like watching the movie instead of seeing a snapshot. So by behavior modification, what I'm talking about is that you can change the dose of insulin somebody takes, the timing of the insulin, the type of insulin, what they eat, the order that they eat, what they do afterwards. All of these things are modifiable to improve blood glucose control. But what's really crucial too, it's a safety net. So hypoglycemia kills people. It frightens people. It causes car accidents and the like. This is something that gets people's attention, and particularly severe hypoglycemia, which I mentioned, 4 to 10% of type 1s are thought to die from hypoglycemia as a direct result. So this is really crucial. So it's a behavior modification device and a safety net. Now, if you look here, you'll see if I have a finger stick and my blood glucose is 80, I don't know where I'm going. But if you look at the center picture there, that cell phone, I have a lot more information there. My blood glucose is 80, but it's plummeting because I have 2 arrows down. So that means it's going to fall by 90 points in the next 30 minutes if it continues. So what that means is I need to take action urgently. This device would also, I wouldn't have to look at it. It would alert me. I would get an audio and a vibration alarm saying, your blood sugar's falling quickly. Call me to action. And it's a huge difference in terms of how useful it is. So if you look at finger stick versus the picture that we get with CGM, so here's a finger stick monitor. So the red dots there represent finger sticks. And so, but if you look at what you get with CGM, that's the whole picture, right? You're looking at the whole movie. So, and there's a couple things that you can see here. So this person, even though their fasting blood sugar was okay, they were getting low in the early morning hours. They need something done about that. That's dangerous. Huge spike up after breakfast. Maybe they had some of the bagels back there, which I refer to as blood glucose explosive devices, but because they increase your blood sugar. So there's a much better picture here. I know what the average is, but I know how it got there and what we need to do about it. So let's look at what are available in terms of real-time and intermittent CGM. There's 4 systems that are commercially available in the US right now. So just as a category overview, this terminology of real-time CGM refers to the patient owns the unit and they're getting active alerts and alarm. The key issue there is active, right? I'm wearing this right now, and if I was dropping, it would tell me. I wouldn't have to inquire, right? So that's the difference between intermittently scanned. So if a patient has a reader or a phone, they have to actively inquire. So it's sort of like dealing with your teenage son. They don't volunteer anything, you have to inquire. Why is a police car out front, right? So, so it's a little bit different. You don't get maybe you get too much information from some of them, that could be. But So let's look. Now, this is an article that I co-authored with Steve Edelman and Jeremy Pettus, Earl Hirsch. It was published in Diabetes Care. And we were looking at intermittent versus real-time CGM. So our recommendation, and this is based on the data I'm going to show you for this, is really all intensively insulin-treated patients. That means basal bolus patients, whether they have type 1 or type 2, would benefit from this, particularly hypoglycemia. So if they have a history of hypoglycemia or difficulty detecting when they are hypoglycemic, that's called hypoglycemia unawareness. And it's common, about more than 50% of type 1 patients have some degree of impaired ability to detect when they're hypoglycemic and also do something about it, counter-regulate to try and raise their blood sugar. So it's a dangerous situation, and it's common. It also occurs in type 2 patients. So people with frequent severe hypoglycemia, nocturnal hypoglycemia, hypoglycemia unawareness, all of them would benefit. They need the alerts and the alarms. They can't be inquiring and pick it up. People who fear hypoglycemia, and it's with good reason. People with high A1Cs, you can lower CGM. People with CGM, and people who have benefited or from these interventions, you can improve the outcomes, and we'll look at that. People who are physically active, because that affects the blood glucose in complicated ways that are individually specific, depending on the type of exercise and how much insulin you're taking. And also people who've used flash or intermittently scanned glucose monitoring and weren't doing well with it. So really, for flash, because you're not being alerted, some people don't need alerts, and they're much less likely to see hypoglycemia, or if they get it, they're more likely to be symptomatic. So that tends to be your type 2 patient earlier in their pathway, not after 20 years when they don't make much insulin. So this is a really busy slide. I'm only going to go through a couple of aspects here, but the different commercial systems that are available. So the MARD is a measure of accuracy. Lower is better, and less than 10% is good enough to drive an insulin pump with blood glucose data. So for Dexcom, it's factory calibrated, so there's an optional finger stick calibration, but it's not necessary. It's factory calibrated. The MARD is 9%, which is excellent. So the Freestyle, it is also factory calibrated. So there's a full replacement for finger sticks unless the patient is hypoglycemic or has impending hypoglycemia. The MARD is a bit higher, 10.1. Medtronic has a version of CGM that's freestanding. That's what we're talking about here rather than pumps. And the MARD there is over 10 if you do 2 finger sticks a day, but if it's 3 to 4 a day to calibrate, it's 9.7. So all of these are better than it used to be. Senseonics, which is implantable, a new product approved last summer, it needs twice a day, and the MARD's about 9% as well. So they've steadily improved. So another feature to call out is remote monitoring. So if you think about if you're a parent and you have an 8-year-old child who has type 1 diabetes, they're at school, they're at their activities, they may be doing a sleepover, you're worried about their blood sugar all the time. So remote monitoring, where the data is automatically sent to a phone, to the cloud, then to you, is particularly invaluable, and we'll go through that in a little more detail. So that's available with Dexcom. It's also available in a more limited fashion with the Medtronic system. So Abbott and Senseonics don't have that yet, right? So this ability to have other people, quote, follow you. For hypoglycemia, particularly people who don't always act on it, that's really crucial. Again, this is a busy slide, but just to point out, what about the age indications? So Dexcom's approved from 2 and up. And non-adjunctive means that the FDA in their labeling says this is accurate enough to replace fingerstick monitoring. You can take doses of insulin and the like without verifying with fingerstick. That was not true until a couple of years ago. Freestyle Libre also has that indication, although it's more limited. because if you're hypoglycemic, you're supposed to verify. Actually, with the Medtronic system and Eversense right now, they're supposed to verify before they act on it. Now, whether a patient does that or not is a different story, but this is the labeling, and it reflects accuracy and consistency and the infrequency of egregiously erroneous readings, because obviously that could be a real problem. So you have to have a high level there. Audible alerts and alarms, I mentioned, these are critical, and they can be individualized to the person's needs. So you can do this with Dexcom. You set a low. You can set when it's falling quickly, N55. The other systems all have a high and a low alert. And also, well, Libre doesn't, but the other real-time CGM systems and can also tell you a rate of change. So more alarms, and you can choose the alarms that are present. So that's important because you don't want people to get alarmed every half an hour because they'll ignore it, right? So alarms should mean something to be useful for the patient. Now, I'm not going to talk about closed loop or partial closed loop systems, but this is just to say that Dexcom is working with Tandem, so it'll shut the basal rate off if your blood glucose is predicted to be less than 80. Medtronic has a more limited CGM where it shuts off if you're actually low for 2 hours, and their more advanced one where it goes up and down on the basal rate. Tandem is also at the end stage of having a system like that as well. So those are moving forward, but most patients with type 1 diabetes type 2s aren't on pumps. So let's look at the clinical evidence. Now this is a busy slide, but this point is quite simple. If you looked at about 2010 in the Type 1 Diabetes Exchange Network, which is academic, about half pediatric, about half adults, what you saw was that there was limited uptake of CGM. They were harder to use, they weren't as accurate, people hadn't been brought on board. So some 4 to 15% more or less of this group that's probably receiving better care than is delivered in the community. So if you compare that, the dark green is 2015. So look at under 6, almost half. And you can understand for parents, this is essential. So the penetration has gone up as the systems have gotten better, more accurate, easier to use, and they've been proven to be effective. Now this also is a busy slide, but I'm making a simple point here. So if you looked at the A1C values in people in the Type 1 Diabetes Exchange, so it's up to 30,000 people now, and looked at their A1C, so this is just observational. If you look at the people who are on continuous glucose monitoring, whether they're on multiple injections or MDI or a pump, they had the same A1C basically, whereas patients who were on a pump alone with only finger sticks actually had a significantly higher A1C. So the implication there is that, wow, CGM really makes a difference in the real world. These are 30,000 people. This was based on 20,000, but it's growing as more clinics are introduced to it. So that's observational. This is a prospective study where they took people who were out of control on finger sticks and injections. Some of them stayed on what they were on, and their A1C didn't change much over 2 years. The group that had a pump introduced but continued to use finger sticks are right there, and they didn't really see much improvement. So there's only a very modest and not even statistically significant improvement over baseline. So that's not to say pumps aren't useful, but the difference between pumps and modern basal bolus therapy is not as big as it was in 1990. But if you looked at this same group, people who either had CGM added with or without a pump had pretty much the same A1C, which was close to goal, 7.172. So again, it appears to be CGM by itself, without being attached to a pump, is a powerful tool. Now, this study was the Diamond study. So many of the early studies were mostly done in patients on insulin pumps, right? And so what this is looking at, it's a randomized controlled study. These are type 1 patients who are on multiple injections, who are doing finger sticks, but their A1C is in the mid-8s, so they're not controlled. And they either continued on finger sticks or they got CGM. And what you saw was at 24 weeks, the A1C went down by a point on average. And at over 50% had more than a 1-point drop. and a higher percentage were able to get greater than 7 or less than 7 versus using finger sticks. The finger stick data isn't shown here, but the difference was about half an A1C point. That doesn't sound like a lot, but it is a lot, actually, because half an A1C point is what the FDA considers clinically significant reduction in blood glucose, which presumably then decreases bad outcomes. The other thing that they saw in this group was less time in hypoglycemia. So you're going to be hearing this as a recurring theme about hypoglycemia. It was reduced by 80% time in hypoglycemia. So these patients had a much lower A1C with less hypoglycemia. That's having your cake and eating it too, although hopefully they're not eating a whole lot of cake. So now this is a type 2 patient. They did exactly the same study in type 2 patients on multiple injections who also started in the mid-8s. And because a lot of times people tend to blame the victim with type 2 diabetes and don't understand really that this is a difficult disease. And actually, as more people survive for longer because we're better at preventing cardiovascular outcomes, they live long enough to outlive their beta cells. So we have lots of long-term type 2 patients who need basal bolus therapy. That is, they need 4 shots a day for blood glucose control. What you're seeing here is they showed almost the same benefit that the type 1 patients on multiple daily injections. So you don't need a pump, and it worked in type 1 or type 2. The other thing they found for type 1s, it didn't matter your education level, your age, your baseline A1C. The more it was, the more you dropped. Income, et cetera. I mean, basically across the board, people did benefit from this, even if they weren't very good at math. And I think most of us accept a lot of Americans aren't good at math. All you have to do is listen to any news report recently, and you see Americans must have some problem with math. I won't say anything else about that. We are in a blue state. And if you're from a red state, welcome. But anyway, so GOLD study, this is a question. What if I use CGM for 4 months? Would I kind of figure everything out and then I didn't need it anymore, right? Is this a tune-up and then you go like training? The answer to that is unequivocally no. So this is a study where they had multiple daily injection patients who either got CGM, came off of it, and stayed at finger stick, or they got finger sticks and then got CGM. So what you saw, the first line there, the blue line shows that their A1Cs went down, but that was for the 4 months where they were on it. The hashed line, they're off of it now. So they lost all of the benefit, essentially, that they gained. So what this means, and this has been shown for pumps too, these are multiple daily injections. The patients who then later started CGM, that's the orange or red line, showed the same benefit. So you have to use it six or more days a week. Studies have shown that. And it's an ongoing way. It's not that you just take it and don't need it anymore. It would be a little bit like if you're an experienced driver, then I say, I'm going to put duct tape over your gas gauge and your speedometer. And let's hope you don't run out of gas and you don't get tickets. So you maybe figured it out, but maybe not. So it needs ongoing use of these. This study, the studies I've talked about so far were sort of different. What's different about this one is very important. This is real-time CGM in a group of people who have hypoglycemia unawareness or severe hypoglycemia. So this is our most at-risk group, right? A lot of them have been excluded from the studies because they didn't think you could randomize people. But here they said, well, we have to prove that this helps in people with this history that is so common. This is half of the type 1 population and a significant portion of the basal bolus type 2s. So if you look the A1Cs before and after, didn't change in the group that just stayed on finger sticks. Those are the first 2 bars. And what you're looking at here is time less than 54, which is 3 millimoles, which basically is the level at which your brain is not getting enough glucose to function properly. So you're going to become impaired, you're more prone to accidents, adrenaline levels go up, so this is a dangerous situation. So that's where severe hypoglycemia happens when you're less than 54, generally. So if you look at the patients who had a real-time CGM, they were able to reduce the time, the frequency of getting less than 54, so these severely low numbers, by 2/3. So they're getting it 3 or 4 times a month instead of 11 times a month. That's a huge difference. And if you looked at something else, focusing on nocturnal nighttime hypoglycemia, which is frightening and dangerous and disruptive, they saw a similar finding. That is about a 60% reduction in the frequency. So what you saw here was somebody went from every 10 days having a low at night, which is frightening, as I mentioned, and dangerous, to once a month. That's a huge advantage. They also showed reduction in severe events where they needed outside intervention. Now, it didn't go away 100%, but what the studies have shown, my experience backs this up, is that people who have a severe event when they're supposedly on CGM, it's one of 3 things. They weren't wearing it at the moment. You have to wear it. It doesn't work on the medicine cabinet shelf. But the more often thing is that they got an alarm and they failed to act on it. So it's a patient education thing that if it tells me, if this is going off and telling me I'm hypoglycemic, I need to act on that information. And that's why I have some orange juice here. If that happened, I could act on it, right? So this is a patient education thing. We do reduce severe events, but patient needs to know you can't ignore alarms. So this is for intermittently scanned CGM. So this was a different study. So what they did was they took people on multiple daily injections, and the baseline A1C was pretty good. And they wanted to see if they could reduce hypoglycemia. Now, they excluded people in this study with a history of severe hypoglycemia or hypoglycemia unawareness, that is, they weren't able to detect it. So those people were excluded from this study. And they were scanning about 15 times a day. So they did reduce by about 40% the time spent in hypoglycemia with no change in A1C. So here it did replace fingerstick monitoring. People were very motivated and scanned frequently, but didn't have a history of severe hypoglycemia, could reduce hypoglycemia. So that was successful as well. Now, this is type 2 patients with the same device, intermittently scanned. Here they were trying to see, could this replace fingerstick monitoring without losing control of the A1C? Their baseline A1Cs were too high. They were about 8.7. So these are basal bolus type 2 patients, so long-term type 2 patients. Remember, think of them as kind of like a type 1 patient with insulin resistance, so it's almost like having double diabetes. So what they showed was in orange versus green, there was no decrease in A1C versus the people who just continued on finger sticks, although they were able to reduce hypoglycemia in this group where they excluded people, again, with severe hypoglycemia. Actually, the elderly patients did better with finger sticks. That's hard to know. That contradicts what's been shown in some other studies, at least with real-time CGM. So that's the replace study. Again, so here's another study. Simple point here. So this is the only study that actively takes people with a history of impaired hypoglycemia awareness or severe hypoglycemia. So that's our most at-risk group, and that's actually half of type 1s. And gave them, had a baseline time period, looked at time in hypoglycemia, which correlates with the likelihood of getting severe events. And if people had intermittently scanned device, there was no reduction in time in hypoglycemia in this group that weren't aware, right? So it's different than the other ones. The other group excluded these patients. But with the real-time CGM, they basically cut the time in hypoglycemia in half with no change in A1C. So here your objective was to reduce hypoglycemia, and it did work with real-time CGM, active alerts and alarms, as opposed to passive CGM where there was no benefit. There was an extension of this that went on where they took the people who were on intermittent and put them on real-time, again, active alerts and alarms, and they showed the same benefit, about a 50% reduction in time in hypoglycemia. So what that means is that alerts and alarms can be annoying, but they're really important, right? So if a smoke alarm goes off at night, if it's a false alarm, I'm ticked off. But if the house is on fire, the problem isn't the alarm, the problem is the fire, right? So that's really important that alarms mean something to the patient and they act on these. So to summarize then, real-time CGM Studies have shown a reduction in A1C and hypoglycemia in multiple different patient groups, including type 2s on insulin. CGM needs to be worn all the time, continuously, to get the most benefit out of it, so it's not something you just do a few months out of the year. Real-time CGM has shown benefit in a wide range of patients, so that's into anybody who's intensively insulin treated, meaning basal bolus or an insulin pump, problems with hypoglycemia, severe hypoglycemia, and in that group, intermittently scanned CGM, which hasn't shown a benefit in this group of patients, is really not the best therapy for them. CGM is appropriate standalone. It doesn't have to be given after a pump fails. I showed you the data. That's really a powerful tool. So I'm wearing an insulin pump. I have CGM. And I got a CGM personally about 12 seconds after it became commercially available. But so if somebody said, you can only have one device, which would it be? For me, hands down, it'd be CGM rather than a pump. Now, I wouldn't want that choice, but it's important that this is really a powerful device in and of itself with multiple injections. And also, a wide range of patients did benefit. It didn't have to be your retired NSA people. I mean, these were, regular people that couldn't do math particularly well, but they showed a benefit. They figured it out. They got some instruction and were able to improve their blood sugar control. So let's look at some of the approaches. What do you do with this information, right? So you want to act on it in the real time. That's what I want the patient to do. And you talk to them about the importance of acting on hypoglycemia and trying to modify behavior. But also in retrospect, we can get that information and do some things with it to get better treatment overall. Dosing off of the trend arrow has now been advocated and published by the Endocrine Society. And I'll show a version of this that I use that I think is quite simple for patients, and also remote monitoring. So the idea with remote monitoring, I went through this a little bit before, but so, if you have that mom with that 6-year-old, that 6-year-old is not in your space most of the day, right? So if they're down the hallway at night, you'd like to know what their blood glucose is without having to get up, go down there, do a finger stick. Hopefully you don't wake them up. Or when they're at school or play or whatever else they're doing. Teenagers, when they're driving, you hope you can shut off their Wi-Fi and so on, but you don't want them to be hypoglycemic. So remote monitoring is critically important in children. It's shown better control in the children that have this done and less hypoglycemia. And the adults actually sleep better as well because they know they're going to get alarmed if the child's in danger. Now, how about adults? So does that matter? Well, I'm married. My wife is not following me with my blood glucose data because it actually probably drive her crazy. But she doesn't need to know because I act on alarms and I'm a light sleeper. But if I were a heavy sleeper and didn't always respond at night and I was away, she would get an alarm, or I could set it up so she would get an alarm, could call the hotel and so on. This can be really important for people who have difficulty waking up when they're hypoglycemic. Also for elderly patients, we have lots of type 1 patients on Medicare now, right? And so if I'm 75, I live alone, and I get a hypoglycemic reaction, and I'm not acting on it, my next door neighbor or family member gets that information. They know you're in trouble. So that's invaluable. It's not available with all systems, but I think for a select group of people, which is all kids and some adults, it is. Now, this information, think of what they have. So they have the picture. So you have where you are now, but you also have where you're going and how fast, right? So that's the trend arrow. And people we try and get them to dose based on what they're eating and their activity level. But this adds a new dimension to it, completely new, because when if my blood glucose, like that first example I showed you, if it's 80, but falling rapidly, I need glucose right now. I'm not going to need to wait until I'm low and maybe disabled. So that would tell me. Now, how about on the other end? So say if my blood glucose is 150, but it's going up rapidly and I'm getting ready to eat a meal, I need more insulin. So this is a way that it's a simplified version of what the Endocrine Society does, but I think it's more practical. It's very simple. This happens to be with Dexcom CGM, but in 30 minutes, you go up 30 points, 60 points, or 90 points, at least. And down 30, down 60, down 90. It's all over half an hour. It's all 30, so I call it the rule of 30. So the patient act on hypoglycemia before it's there, and also you can add this to their scale coverage, add the two numbers, right? So this allows, more aggressive dosing with more information because you know where you're going, not just where you are. Now, software options, are also available. And so in real time, we want the patient to be looking at this and acting on it, using the information. And, there's a learning curve with that. It takes some attention to it, and they learn quickly, though, actually. That's what some of the other studies have shown. When you start people on CGM, they figure out pretty quickly some modifications that they can make. And obviously, the clinician can help them, further refine that. So software is important to look at the data in retrospect. So Retrospective CGM Analysis is really a powerful tool. So about half of my patients have type 1. Currently, about 75% of them are on CGM. So I spend all day looking at these downloads, and they're really invaluable. I'll show you an example of one. For some, you store it in a receiver, but some of the systems now automatically upload that data to the cloud, so the person doesn't have to plug something in and actively download. So that's really invaluable because you're getting all the data captured to look at it. They might look at it, I might look at it, or they might call me up and say, something's wrong, I'm getting low a lot at night. I can pull it off the cloud and I can look at it without the person coming in. The tracings give us a lot of information about hypoglycemia and patterns. What can we change? Your A1C is too high. How do we fix that? So the systems that have that right now are Medtronic, Dexcom, and Eversense. They have software and can be uploaded. Libre has that capability, but if you just use a receiver, it has to be manually downloaded. So we do want to look at the data. Now, this type of graph is perhaps a bit much after breakfast, but it's actually really crucial. This is a summary that's so much more informative than is an A1C. So if I tell you somebody's hemoglobin A1C is 8, how do I fix it? Are they getting hypoglycemia? Are they getting low at night? Are they really high at night? Do they go up really high after breakfast? I don't know how to fix it. It just tells me generally what the average blood sugar is. So here, you do have the average blood glucose. For this person, it's 160. So as a benchmark, 155 equals an A1C of 7. So that benchmark that we're usually shooting for, I know this person's slightly above it, so their A1C equivalent is probably 7.2. There's some other things I get from this, though. So now I know what your actual average is. The reason we want to lower average blood sugar is that you reduce eye, kidney, nerve, heart problems. But if you're concerned about average blood sugar, let's measure average blood sugar directly rather than using a surrogate marker, the A1C. So that allows me to do that. The other things I can see here is the second thing I'll look at is hypoglycemia. How many of the readings were less than 70 or even less than 55? And here I can see for this person, it's about 4% of the time. Now, you see percents, people kind of glaze over. It's actually very simple. 1% of the day is 15 minutes. 4% is an hour a day. So I translate it into time. I can also see how much variability they have, that they're using it. And that graph there helps me figure out if the average is too high, when is it likely happening, right? So that's the average, that purple line, 50% are in the blue line, 80% are in those dotted lines. So I get a lot of information in seconds from this, tells me what should we deal with this visit. Or maybe you're doing fine, and then we can talk about baseball. So doesn't happen too often, but particularly not if you're an Orioles fan. That's actually a tough subject too stressful. So how about the cost savings associated with CGM? So in an ideal world, everybody would have access to everything, but obviously for insurance companies, they need to look at the cost of something versus the cost that it offsets and the improvements that you get. So this has been looked at, and to give it a frame of reference, the reason we care about this is, as I said, most people don't get their A1C as low as optimally it should be to prevent long-term complications, which are expensive. We know that fear of hypoglycemia interferes with the ability to lower average blood glucoses in people, obviously all type 1s, but many type 2s as well. And only about 30% of insulin-treated patients have an A1C less than 7, so they're at a higher risk for low or high blood sugar problems. Hypoglycemia is very prevalent in type 1, but it's also prevalent in type 2. And it can require costly short-term intervention or cause a car accident. And then it doesn't just put that person at risk, it puts you at risk if you're at the same intersection or your teenage daughter. Hypoglycemia unawareness is been, some degree of it has been said to be 63% of people with type 1. So the longer somebody's had type 1, the more likely they're suffering from this. And it's a significant proportion of the type 2 population on insulin, it's about 50%. Severe hypoglycemia contributes to death, as I mentioned, adverse outcomes. If somebody falls, breaks a hip, and aspirates, that's going to be an expensive hospitalization. Other than a traumatic event for that patient, it's going to cost a lot of money. And hyperglycemia over time also causes problems. So we're not doing a great job right now on controlling average blood sugars and preventing hypoglycemia with finger sticks. So this is a little bit of a busy slide, but the point is actually quite simple. So if you look at green are the type 1s, and in blue are the type 2s. What intervention did they need when they had a severe event? And what you can see, ambulance transport, ER treatment, and hospitalization, the percentage of people from a large study that needed this actually was about 12% of a severe event in a type 2 led to a hospitalization. The average hospitalization cost was $13,000. ER visits were about $800. ER transport, ambulance transport, about $1,800. So those are expensive, and they're not rare. You're seeing this in 40% of those episodes required an expensive intervention. This is a really busy slide, and it's a very simple point. This is a cost modeling thing where they said 1.4 million patients. If you got the people, that is about 3,000 people, 3,500 people that are high risk with hypoglycemia in this group, and gave them all CGM and looked at the cost of CGM versus the offsetting costs, 60% lower rates of ER visits for hypoglycemia, hospitalizations, and the like. So basically what you would do is by spending $11 million for these patients, you would have saved $8 million because your expenditures on adverse events went down. So there's other data showing cost effectiveness by the standards that are usually used and accepted with real-time CGM at least. So now here's a study called the Rescue Study. So what this is, in the Netherlands, they made CGM available. So these are both real-time and flash CGM, intermittently scanned. And what they showed was, let's look at the year before and the year after in terms of expenditures for hospitalizations, DKA, and absenteeism from work, which is a big thing. So about half of the patients, the reason they started was hypoglycemia. About a quarter were just poor control, and some were pregnant. So people used it full-time 90% of the time. The quality of life really improved. But these are the baseline levels before CGM, the year before it, and how often the percentage of people and the rate per 100 patient years of how much a diabetes-related hospital stay, hypoglycemia-related stay, DKA, diabetic ketoacidosis stay, absenteeism from work. So this is a sick group that's generating a lot of medical interventions that are costly. This is what it looked like the year afterwards. Dramatic reductions in diabetes-related admissions, hypoglycemia-related admissions, DKA-related admissions and absenteeism from work fell by 60%. So these patients are more likely to be able to remain gainfully employed and productive citizens, which, of course, that's what people want, right? So this, in the real world, that more than paid for the cost of the CGM. Now, HYPO ratings obviously are important looking at healthcare plans, and you would know more about that than I do. But if you look at percentage of A1Cs less than 8, and if you look in the type 1s, they fell by 1 point on multiple injections. Type 2s had a similar reduction. And type 2 with a baseline A1C fell by 1.4. So your numbers in terms of less than 8 and also less than 7, excuse me, are going to improve. So because of this, all of what we're talking about, CGM is a new standard of care for patients with intensively insulin treated, and that's according to AACE and the Endocrine Society. And it's generally accepted by insurance companies as well. But intermittent scan CGM should not be used in people with a history of severe hypoglycemia, nocturnal hypoglycemia, or hypoglycemia unawareness. So this is a summary slide here. So patients use CGM data for proactive course correction. Right now, you can act on it. The clinical evidence, professional societies endorse it as the standard of care for intensively insulin-treated patients. Downloading information is invaluable to try and refine therapy, and sometimes there's a teachable moment. If I look and there was a prolonged hypoglycemic reaction, that's what we're going to talk about, like how to deal with this, why did it happen, paying attention to it. And cost modeling shows that money is saved even if you account for the money that's expended for CGM. So with that, I will stop, and I would be happy to answer any questions. I'd like to thank you for your attention this morning, and thank you. So we have about 10 minutes. If somebody has a question, and I guess we don't have mics here, but if you have a question. Is it reimbursed by Medicare? So I'll try and repeat the question. The answer is yes, under certain circumstances. So I was actually involved in that effort to try and get Medicare to cover CGM because I have a large CGM population on Medicare and a large type 1 population on Medicare because we've been successful at keeping people alive long enough to survive to Medicare. So Medicare has to be able to cope with the exploding number of type 1s that end up at that age group. So that was a big problem. If you're covered by commercial insurance, you retire, and now you say, what do you mean you're not paying for this? I need this. This is life-saving, life-essential. So it really put people in a bad situation. So Medicare, after a lot of effort and education, they needed to have FDA non-adjunctive approval, meaning that the device is approved for direct dosing. So it's not, it then can essentially replace finger sticks except for the need to calibrate if you had that. So they would give it to either type 1 or type 2 if they're on multiple daily injections, or pumps. So they need to be on at least 3 injections a day. They need to do 4 finger sticks a day. They don't actually define the time period, but I'd say a month just because that's what Medicare requires for other things. They need to be seen at least every 6 months, and they need to have to use the information. So that's actually type 2s on multiple injections, or all type 1s are now eligible if they meet those requirements, which are actually better than most commercial insurers because they skipped over the part where really type 2s on basal bolus therapy are discriminated against because it wasn't covered. So the uptake in the Medicare population has kind of exploded. There was a lot of pent-up demand. So it is people are Medicare eligible for at least 2 of the systems because they have to have non-adjunctive indications. So right now, Dexcom and Libre are both approved for use with Medicare. The other 2 systems as of now are not. And the only way they could get that, unless something changes, is they'd have to have the approval, meaning you have enough accuracy and a low enough incidence of wildly aberrant numbers that you can use this directly, that is a replacement for finger sticks. So that was a great question, because the Medicare population, you know, a joke I like to make with people is, I want you to survive long enough to help bankrupt Social Security, but not Medicare. So how do you do that? You live a long time and you stay out of the hospital, right? And so this helps Medicare patients avoid hospitalizations. You can run their blood glucose at an appropriate level for that patient. And I had 3 Medicare patients die from hypoglycemia that were waiting for CGM. So this is not a hypothetical issue. It's really critical. And so it's been a game changer for a lot of those patients. So studies for use in pregnancy. So none of these are labeled as being approved for use during pregnancy. However, that's not the question you asked, right? Are they used in pregnancy? So me as a practitioner, absolutely yes, because I do see my type 1 patients, when they become pregnant, they are usually on CGM, but we want them on CGM because during pregnancy, you're trying to keep the blood glucose is not just at an A1C of 7, you want an A1C of 6 with post-meal blood sugars less than 140 and fasting less than 100. That's tough, and it induces a lot of risk for hypoglycemia. So you've got 2 patients. You're trying to protect the fetus as well as the mother, and that's a tough thing to do. So anecdotally, it's helpful. Now there was a recent study, a number of studies here where they're showing improvements in use in CGM with perhaps not a difference in A1C, but reductions in hypoglycemia and postprandial blood sugars. And so if we can address the post-meal blood sugars, you'll have fewer macrosomic infants that require a C-section that then have to go to the neonatal ICU because of hypoglycemia and the like. So there are better outcomes. So it's still preliminary, but it's not labeled as such. But if you go to, if you were pregnant and you had a CGM and you came to my office and you said, I'm pregnant, it's like, congratulations. Well, the FDA says this isn't approved for pregnancy, give me your CGM. Would you turn your CGM over? Probably not, right? You'd find another doctor. So what FDA labeling and what, as a practitioner, you do are different. So it isn't, but it probably will become approved, I would imagine. It's just they're much tougher studies to do. Right. About gestational diabetes. So there's less data with gestational diabetes. So just to distinguish, if you're not familiar, so the diabetes of pregnancy is actually 2 entities, essentially. One is pre-gestational diabetes. That means you had diabetes and now you're pregnant. So you're hyperglycemic through the whole pregnancy. Gestational diabetes is generally somebody often predisposed to diabetes who becomes hyperglycemic generally in the 3rd trimester. And so there's less evidence for use of CGM in that population, but that may be a role for somebody using a system just while they're pregnant and maybe then stopping it, because as a replacement for finger sticks, what we're asking gestational patients to do is check fasting at a minimum, check fasting in 1 hour or 2 hours post-meal. That's already 4. If you're on insulin, you need before meal, after meal, in the middle of the night. Now you're up to 8 finger sticks. Your fingers, that's hard to do, right? So CGM, although it's not proven, I think would be very attractive in that group of people. And you have options now that allow that. So it's educational. It helped the doctor change therapy, but also reduce the risk of hypoglycemia, which is a real issue in that patient population if they're pre-gestational diabetic. So limited data, but I think it's promising.
There are payer that's covering intermittent CGM for type 2 patients.
Intermittent? You mean, well, so I take it, so the question is, are payers covering intermittent CGM? So that's actually a different model, and I hadn't discussed that, but it's important to talk about. So everything we talked about was personal CGM, meaning the patient owns the unit and they're using it hopefully all the time, or at least that's what the expectation is. So there is another model which actually for type 1 patients, don't kid yourself, is not useful, which is to have somebody do it for 7 to 14 days and then go over it with them and try and tune it up, right? So now that's, for type 1 patients, it's not adequate. I showed you, if you wear it all the time and then you take it away, they lose the benefit. So doctors are kidding themselves if they think that that's useful. Sometimes it's better than nothing, but you can't show benefit. How about type 2s? Actually, for type 2 patients, I do a lot of these professional units where we have a unit, excuse me, and the patient can either see the data or just review it later, but it gives me what their average is, their patterns are, and many payers will pay to do those intermittently, so-called professional or diagnostic CGM. And so I think those are valuable, and for type 2 patients, sometimes if I know they need to intensify the treatment but they're resistant, they can see the data. They say, oh, okay, geez, look what happens when I eat corn chips. And so it might prompt them or the physician to intensify therapy. Another situation where it's really useful is, and I didn't go into this, but the hemoglobin A1C, on average, an A1C of 7 equals a mean blood glucose on CGM of 155. That's a benchmark. However, you can have an A1C of 7 and have an average blood sugar of 125 or 190, even if you're hematologically normal. So there's wide variation within individuals between the correlation of A1C and mean glucose. And essentially it has to do with how long your red cells live. So people who have robust red cells that live a long time, they're actually going to have a higher A1C at the same average blood sugar. People who have shorter-lived red cells, the opposite is true. And like dialysis patients, A1Cs are not useful really because they underestimate glycemic exposure. So if there's a question that the fingerstick data and the A1C don't jive with each other, it's invaluable because at least I'm going to get an average blood sugar, a true average, that you can extrapolate to whether it is and see whether that A1C is really diagnostic or not, right? So for people who have an A1C that is discordant from fingersticks and other measured glucose data, that will be consistent. That's not a fluke. That reflects their intrinsic biology. It's mostly due to red cell life. If you look at red cell life in the population, it's a bell-shaped curve of people who are hematologically normal. So some people, the average red cell life is 41, some it's 57, I mean the average age of the red cells. So this adds information to the A1C. Plus also, if I'm worried you're on basal insulin, I want to make sure you're not getting nocturnal hypoglycemia. This is a way to find out. So it's really valuable. Most insurers will cover in that situation, at least under some circumstances. And I think they should. That's a model of intermittent use that's different than what I said about type 1s. They need it all the time. But people who are not down that pathway, it's a bit different. So it looks like we're at time. Thank you for your attention again and the great questions. I would be happy to answer any other questions up here at the podium if you have them. And thanks for attending today.